for your time and the opportunity to share with you a little about PAHO and the Health in All Policies approach to doing work. My name is Brittany Jones, and I'm the project assistant with the PAHO Country Office for the Bahamas and Turks and Caicos Islands. And before we jump in, I just want to know, has anyone ever heard of PAHO or know what PAHO does? I love an interactive audience, so feel free to unmute your mic. And once I go in presentation mode, I won't be able to read the chat, so feel free to talk back. Has anyone ever heard of PAHO and knows what we do? If the answer is no, that's fine. We could quickly go through it before jumping into the presentation. Okay, if there's silence, then I will assume no. So PAHO is the oldest international public health agency in the world, and we were funded back in 1902. It's an intergovernmental organization, which means we work very closely with the Ministry of Health and Wellness, as well as other governmental agencies as well, to deliver what we call technical cooperation for health. Basically, that means the public or the Ministry of Health and the health authorities define a set of priorities, and they work alongside us, or we work alongside them to deliver technical cooperation. Could be in the form of projects, could be supporting programs, etc. Our ultimate goal is to see an improvement in the health and well-being of the peoples of the Americas, and the region of the Americas includes North America, Latin America, the Caribbean sub-region. You can think of us as the regional arm of the World Health Organization. So there are multiple regions like the European region, the African region, the AMRO region is what we are classified as, the Americas, the region of the Americas. And PAHO actually wears 4 hats. So we're a part of the UN, or the United Nations system. We're also a specialized agency of the OAS, the Organization of American States. We're a part of the Inter-American system, as well as, like I mentioned, the regional office for the WHO. There are a number of countries that are covered by our various country offices. So we are just about everywhere in the Caribbean, from Belize, Brazil, Costa Rica, Panama. So all of our country offices are pretty much doing the same things of delivering technical cooperation to the various countries. And the last thing I'll share is that our primary areas of work, I'll quickly share my screen just so you can see, is very broad. And so we have communicable diseases, things like COVID-19, as we've been battling through, TB, HIV, vaccine preventable diseases, non-communicable diseases, or NCDs, things like diabetes, cancers, violence, injuries, nutrition, determinants of health, or health throughout the life course, so issues around equity, gender, aging, health environment. There's health systems, thinking through how we resource the health system with human resources. How do we make sure people have access to the right medical products and technologies, as well as the health policies that govern the health system. Of course, health emergencies, we would have had a significant role to play post Hurricane Dorian and all of the previous health emergencies and disasters in the country. And finally, leadership and governance. So it's just a quick sort of overview of the kinds of things that we do. But just wanted to start there so you have some background and some context of who is PAHO, what do we do? So I will move into the next presentation, which is where I'll spend the most of my time, and start by asking, does anyone know what is the definition of health? If you had to define health in 1 or 2 sentences, how would you do that? What is the definition of health?
Good morning, by the way. My name is Kushay Meka. I would describe it as having a state of well-being.
Okay. Anyone wants to add to Ms. Mather's response? Thank you. That was a really good one. Any other ideas? What does it entail?
In school, we learned the WHO definition, which is
Okay.
a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So that's an option.
Yeah, absolutely. That's exactly where I was going. Thank you both. So, as you said, our approach to thinking about health is holistic. We're not just thinking about the physical well-being of a person, but how they're doing mentally and socially is just as important. And so we're not just thinking about whether or not they're sick, but a holistic approach. I also want to highlight that it is a fundamental right of all people, regardless of their background, their beliefs, etc. It's something that we all have the right to obtain our optimal health and well-being. And it also includes provision of adequate health and social measures. So when we talk about health and social measures, have you ever heard the term social determinants of health? Or does anyone know what does that mean when you hear that term? Or even if we just took it out of social, when you hear determinants of health, let's just start there. What do you think about?
It could be factors that affect your quality of health.
Yeah, absolutely. Thanks, Livan. So determinants of health or social determinants of health are basically these conditions where people function every day, where they are born, where they live, where they grow up as children, where they go to work, how they age over time. And it is really affected by the distribution of resources. So people who have access to more money and power may have different health outcomes compared to people who may not. And it's not just at a global level, but some of these phenomena or the differences in health outcomes can be seen at the local and the national levels as well. Just think about whether or not persons in family islands have access to the same services as persons in the capital, and what kinds of services do they have to come into the capital to obtain. Think about pregnant women and them coming in after a certain amount of time to deliver safely at the hospital. And whether they have access to the money and the resources to do this, as we can see, can have an impact on health outcomes. So there are many determinants, as we call it, to health and health inequities, which we'll touch on in just a little bit. Some of them are social in nature, some of them are environmental in nature, and some of them are economic in nature. And what I want you all to realize is that the determinants of health lie outside and within the health sector, meaning as blooming physicians who will soon walk across that stage like your colleagues did yesterday, when you start treating your patients, you need to think about what are the other factors that determine why they're sitting in front of me today. And we'll dive in a little bit deeper. This also means that in other sectors of life, whether it is the education sector, the water sector, etc., any decisions or policies that they make have an impact on human health. And so you need to think globally or think holistically in terms of how you're treating patients and what sorts of factors need to be addressed. So on the left, we have the first graphic, which basically shows us a person who is battling with a particular health hazard. And all of the issues that they have to face will determine how well they fare. A person who is in poverty, who has poor housing condition, who's unemployed, who has poor access to food and nutrition or lack of education will all determine how well they're able to fare. So one thing you may tell your patients is make sure you get good exercise on a regular basis, go outside. But if their environment is unsafe and there's a lot of violence that they may be exposed to, that is a hazard that may impact their ability to go out on the park and walk safely. Or if you tell them to take better care of their respiratory health, but they live in a situation of poor housing and substandard conditions, then you may constantly see them coming to the ER for asthma bay or for some other treatment, because the underlying factor is what you need to think about, not just acutely what they're presenting with. On the right-hand side, we see a similar representation of this concept, and it's called the socio-ecological model, where at the middle, we have individual people, individual choices and lifestyle factors that determine how well they are, whether they smoke, they drink, they exercise, they eat a healthy diet or not. Those are individual factors. Then you move outwardly to the social and community sort of impacts on their health. So some of them we've touched on already: housing, water, work environment, education, etc. Those are your living and working conditions. And then we filter out again, and we need to also think about what is the impact of culture on people's health outcomes, and how does that translate to the social level and the individual level. So to this concept of equality versus equity, this is always a graphic that we enjoy showing, just because on the left-hand side, the far left, you can see that equality is this concept of giving everyone access to the same resources. But inherently, there are some persons that are super tall, there are some people that are medium in height, and some persons that are very short. And so giving everyone the exact same access to the exact same resources may not fare well. In fact, it may give an unfair advantage to a person who already is tall. And so when we move toward equity, it's this concept of giving people exactly what they need in order to obtain the health outcomes that we desire to see. So the shortest person needs 2 crates to be able to enjoy this baseball game, and the person in the middle only needs 1. And as you can see, the person on the left needs nothing at all. But ultimately, we want to get to the point where we can remove, proverbially or metaphorically, remove the fence, so that any of these avoidable differences or avoidable factors that impact human health and the health outcomes of a population are completely removed, and everyone can enjoy the same optimal health, or in this metaphor, enjoy the baseball game. So health equity has to do with observable differences between various groups of people, and inequity is the presence of these unfair but avoidable and remediable differences among various groups of people. So at the global level, there's recognition that we need to do work on improving the health outcomes of various peoples. If you know anything about public health, we work at the population level, and public health is becoming more and more global as we live in a globalized world and a globalized society. So when we think about improving the health outcomes of the world and ensuring equity across the globe, the United Nations came up with, firstly, the Millennium Development Goals, and then later transitioned to the SDGs. So the MDGs have 3 goals that were focused specifically on health outcomes, one being reduction of child mortality, one being improvement of maternal health, and one being the combating of HIV, AIDS, malaria, and other communicable diseases. And so I won't go through all of them, but the point here is to highlight that among those 3 health goals, we've been able to make some progress. So we've not gotten exactly to 100% on all of our goals and targets, but we have been able to achieve a reduction in child mortality because we've been giving more vaccines and increasing the vaccination coverage. So a 40% decline in under 5 mortality and an 11% increase in measles vaccination coverage. Regarding MDG 5, we've seen an improvement in maternal health, where the mortality ratio decreased significantly, and that's because we're having more women who are delivering and giving birth in the presence and the attendance of a skilled healthcare worker. And then finally, regarding MDG 6, we have a 17-fold increase in the number of persons on antiretroviral treatment. So they're faring better with the infection. And also because we've been distributing mosquito nets and insecticide, treated mosquito nets, etc., there's been a reduction in malaria and those sorts of vector-borne diseases. So once we switched over to the Sustainable Development Goals now, the MDGs were between 2000 and 2015, there was this recognition that there's still more work to do. We did not accomplish everything that we had set out to do, and so there's an unfinished agenda, and we are now in the era of the Sustainable Development Goals. And they seek to address some main dimensions of people, planet, peace, prosperity, and partnerships. And I'll show you the graphic for it in just a second. The SDGs, like the MDGs, have a number of targets, indicators, things that help us to measure how well we're doing and how we're improving over time. Again, with the ultimate goal of reducing inequities within countries and between various countries. So you would notice firstly that the MDGs were fewer than the SDGs, and some of the focus, or a lot of the focus, was on communicable diseases, things that are more like vector-borne diseases. And now we switch over to the Sustainable Development Goals, and there's more of a comprehensive approach to how do we achieve good health and well-being, not just for NCDs, or sorry, not just for communicable diseases, but a number of other areas of health. And in the next slide, I'll show you how we've expanded that. But in this graphic, I want you to see that health sits in the middle of every other SDG, meaning the decisions that are made in the education sector, in the food and agriculture sector, in the water sanitation, climate change, any of these sectors have a direct or indirect impact on human health. And when we think about a health in all policies approach, it means that we need to partner with all of these sectors in order to improve health outcomes of people. So I highlight goal number 17, which is partnership with the goals, meaning we need to understand the role of each sector and each stakeholder in achieving our ultimate goals. So here is the SDG 3, specifically the targets for SDG 3. So not only are we still focused on maternal mortality and newborn child mortality as we did in the MDGs, but we've expanded that a little bit more to include NCDs, which, as we all know, accounts for more than 70% of global mortality. So it really is a huge issue across the globe. But also things like substance abuse, traffic injuries, sexual and reproductive health, universal health, this idea of how do we help more people get access to healthcare without going into financial hardship? Are they able to pay for it and afford it? Tobacco control, the healthcare workforce. You all are going to be a part of the healthcare workforce, and we need to think through what are the needs to build capacity and provide the right conditions for healthcare workers to be able to flourish. So all of these things tie into or are determinants of how well people fare. And as you continue to explore your medical career, you might want to take a peek at the SDGs and kind of figure out, well, what thing do I want to do to contribute toward the SDGs and the attainment of these targets and indicators? Just to mention that in the other SDGs, like child malnutrition in 2.2, or access to safe drinking water in 6.1, or natural disasters in 13.1, we have all seen and experienced how these things can impact health outcomes. Violence is a prominent issue in the country. Right now, it seems to be skyrocketing, but it's a common issue. And we see how that directly translates to persons coming into the ER with gunshot wounds or stab wounds. And so again, when you think about health and when a person sits before you, don't just think about treating their physical ailments, but also think about the underlying factors. So the health in all policies approach, as I alluded to earlier, is this collaborative approach where we seek to integrate the work of various partners, stakeholders, sectors to really begin to articulate how does their health decisions and policies impact the human health and outcomes of health across communities and populations of people. We recognize that there are a multitude of factors beyond the health sector and beyond the scope of public health, beyond the scope of medical care that impact how well people are doing. The health in all policies approach provides a way for us to be able to identify where are the unintended impacts of a policy. For example, if there were a policy that says we're going to construct houses 20 feet from a landfill, you can see how the implications of that decision would be very, very detrimental to the people that are living right in that adjacent community. Or if there was a decision to, I don't know, take away all pedestrians or not have sidewalks, we could see how that would pose a threat to pedestrians or people walking the streets, cyclists, motorists, etc. There would not be a safe place for people to traverse the streets and cross the streets. So we need to think about how policies in other sectors impact human health. And so the health sector must, again, capitalize on co-benefits in order to get the best outcome and improve the lifespan of people, really. So a co-benefit can be the example of the decision to reduce the number of cars on the street by encouraging persons to take public transportation. So let's just suppose that our bus system were top of the line, it was reliable, it came on time, and there were frequent routes. So every 15 minutes, there was another bus that came. We could see how people may decide that they want to leave their cars at home. And this can translate to reduction in air pollution, which can also translate to maybe a reduction in the number of persons coming in with respiratory complications. So that's an example of a co-benefit where the decision in one sector can reap health outcome or health benefits rather. So I just want to hear from you for a second, because I've been doing a lot of the talking and I want to hear back from you. For each of the following issues, and we'll start with diabetes, tell me firstly, which agency would you propose to partner with if you were going to take the health in all policies approach in order to address diabetes? Who would you want to work with if you as a physician were an advocate and you realize that I keep treating the same diabetic foot every single week, or I keep seeing patients with issues with their vision and I want to be an advocate, or I want to do work in this space and I want to apply the health in all policies approach? Which agency would you go to, knock on their door and say, let's work together to do something about diabetes? Or which sector? Doesn't have to be a specific agency. Which sector would you go to? Or which industry would you seek to approach?
I'd like to work with the Ministry of Education. In terms of prevention, I would like to start teaching the students early about what are the risk factors that lead to them getting diabetes. And hopefully, if we educate them early on in life, we could start improving their practices so they'd be less at risk.
Awesome. So you answered the second question as well. We heard that your policy or your approach would be education of children within school settings. Anyone else? Which sector or agency, and what would be your recommendation? You were able to approach the food industry or the sugar sweetened beverage industry. What might your admonishment to them be as a physician, or the person that's seeing the other side of what happens when people consume a lot of sugary foods? What policies would you make for access to fruits and vegetables? Maybe you go to I don't know if there's a grocery store association or some way to improve access to fresh fruits and vegetables at the community level. What other policies would you propose?
Talk of maybe like a sugar tax, or I know at one point the Ministry of Health was moving towards the eradication of sweets from schools, especially soft drinks like sodas. So if you're looking at policies, and I would liaise with the Ministry of Health to implement those kind of policies, at least within the children, because it's a bit more controlled. And then for adults, try to discourage the purchasing of those, but not make it infringe on anyone's rights. Yeah.
Thank you for that. It's a good example. Anyone remembers the revision of the breadbasket items and the corned beef war that we had? People were picketing with their signs saying that they wanted corned beef. So you make a good point. Sometimes the recommendations that come forth may be met with some level of opposition. And so there is a balance there. But the point is, there are policy options that we can think through. Like you said, taxation is one of the approaches that governments use to discourage a certain unhealthy behavior. And we can, of course, use the revenue to put back into education or back into service delivery. All right, let's move on to road traffic injuries. Who would you work with? If you saw a lot of injuries relating to speed or motorcyclists who are not wearing helmets, what would you do? Who would you partner with?
I guess I can go again. For me, I would first take the civic approach. So I know Pilot Club deals with brain health and safety. So they do a bit education on making sure you wear helmets, especially even from riding a bicycle. So they start from the children straight up to adults. And then I would work with road traffic to make sure there's enforcement of seatbelt laws, and maybe see if there is a possibility of making some mandate that you have to wear a helmet if you're going a certain speed, or even ticketing, like increase those factors to decrease the behavior.
Awesome. So the point is, you all may not be making these policies, but they may be policies that you can support or get behind because you see what happens on the opposite end. So those are all great examples. What about lung cancer? Let's hear from someone who has not yet spoken.
Maybe you could partner with Ministry of Health just to discourage smoking, like cigarette smoking, any kind of smoking.
Awesome. Yeah. What about the tobacco industry? How do you, that may be tough, but how do you make that argument as a healthcare worker that tobacco smoking or any kind of smoking is harmful? So one of the things that you may consider is that as healthcare providers, you see the patients and you're hopefully also collecting the information, and there's some sort of data system wherever you are working to build the evidence. Within the last year or within the last 2 months, we've seen this many cases of lung cancer, and it's been increasing or decreasing. A part of what helps to strengthen your argument for a particular policy or intervention is the data. No one can refute the facts or refute the trends that your data is showing you. The last one I'll touch on is STIs and in adolescents. Who would you partner with? What would your message be? What would your policy recommendation be if you wanted to reduce STIs in adolescents?
Like the Ministry of Education again, for sure.
You wanted to add to that, Antonio?
I was thinking if I could think about anything else. Who deals with STIs? Like I don't know any STI clinics on the back of my head, but also that would be good as well.
What about at the community level?
Probably like urban renewal.
Potentially. Or your neighborhood association. So it doesn't always have to be a formal engagement to make a difference. You can think nationally or locally. What resources or who do you know in your own circles or agencies that you may be connected to that can give you an in? Could be a youth group, could be the group of children in your community. That's all an effort to sort of curb these types of issues. So I hope that as you go through your career, you kind of find things that you're passionate about and work on the clinical end as well as the other end of things. I won't go through this, or I won't dwell on this very long, but I also wanted to use COVID-19 as an example of the health in all policies approach. And so we saw the Ministry of Health do what? Anyone, y'all just shout it out. What did the Ministry of Health do during COVID?
They provided education on vaccines and other ways to protect yourself during the pandemic.
Yes, they did. What else?
I guess they also provided infrastructure for persons who did contract the virus, as well as those who needed other healthcare measures for previous comorbidities. So also making sure that those persons didn't come in contact with persons who could infect them.
Yep. There were measures for quarantine and isolation. And they're still doing that follow-up work. They've done weekly or daily press conference briefings and things of that nature. Okay, what did the Ministry of Education do?
They converted to online learning,
Absolutely.
a lack of gap in the students' education.
What about social services?
And they provided meal vouchers for persons who needed food. And also at some point they were trying to give Wi-Fi devices to students who don't have access to internet.
And some rental assistance as well. What about Ministry of National Security, our police officers, and maybe Defense Force officers as well?
They enforced the curfew and also they ensured that social distancing was met in public spaces.
Still have that COVID task force. Great. What did the Ministry of Environment do? Think about environmental health. They would have helped to develop protocols for the reopening of workplaces, schools, nurseries, and provided guidance on how do you clean, what is high cleaning, and how do you disinfect surfaces, things of that nature. What did the Ministry of Tourism do?
They would have worked with stakeholders like hotels to develop policies for reopening and ensuring that tourists did not contract the virus while abroad.
Yep, they developed or came up with a set of standards for who gets to enter. What do you need to enter? What do you leave? How do you leave the country safely? And all of this, of course, in conjunction with the Ministry of Health and Wellness. And finally, parents, churches, policymakers, what did they all do? Some parents became teachers as well. Some churches gave out PPEs and other materials, and of course, policymakers continued to shift the, let's say, emergency orders that would have governed a certain period of time. So the point here is that with any health situation, health issue, whether it's an emergency or not, it is clear that in order to impact health outcomes, there's a role for every sector and every ministry and every agency to play. And so as, again, the health sector, we need to know if we're going to improve anything, we need to work with tourism to control cases coming into or out of the country. We need to work with education to make sure children are protected. We need to work with our civil society stakeholders like churches to make sure that they reach their populations of people. So think holistically. So
before you go on, Ms. Jones, I'd like to add one more agency that I think is important.
Go ahead.
And that's the National Insurance Board. I don't know if you want to talk about their role and probably add them to the list,
Yeah, so those
extremely important agency.
Yes, those contributions that are being made, hopefully on a monthly, on a consistent basis, serve as a
safety net.
A safety net, thank you, for these types of emergencies. You just never know when hardship is going to come.
Yeah.
And it's great to be on top of those payments because you just never know. You may need that check for the rental assistance, or you may need that check or the card for food assistance, and there's no shame in that. COVID has shown us the way that anyone at any tier of society can be impacted. Just look at the way we've defined essential worker. The people who previously we may have looked down upon were the exact persons that we relied upon for essential services. And so no one is exempt when it comes to these kinds of situations. And it really takes just one emergency or one disaster to literally bring us to our knees. So yes, agencies like NIB have a critical role to play.
I think they actually had an unemployment benefit because so many persons, were put out of work, especially in the hotel sector. So that provided them with that support that they needed, months of unemployment.
And people are still now coming back to a sense of normalcy. And for others, we know it'll take a while before they really do get back on their feet again. Thank you for that intervention. So as a physician now, you may be thinking, what do I do with all of this information? How do I make this practical and relatable to me? Well, firstly, as you deliver healthcare services, remember that you're not just working on the treatment, but also think about prevention. Think about all of the factors that determine how well a person is able to manage their disease, especially vulnerable populations like your pregnant women, people with disabilities, the elderly population, children. How can they be impacted differently? And what sorts of things that can you do to work not just on the curative and treatment side, but also the preventive side as well? Of course, work in collaboration with all of your non-health and health stakeholders as well, and think about community level, national level, and maybe even global level as well, and come up with actionable plans with specific activities that can easily be implemented, or sometimes it's not that easy, but that can be implemented to address not just physical health and well-being, but also mental and social. I know that there was some guidance during the quarantine period for people to just be in nature for a minute, like just sit in green spaces. That can help to hit the reset button on the mind. Or if you need to talk to somebody about the distresses that came along with COVID-19, do that. Think holistically, and you may need to work with partners, maybe in social services, to get housing assistance for somebody, or food stamps, or whatever it is, to help persons actually get back to a place of well-being, not just physically, but holistically. And then make referrals to these non-health sectors. So again, if a person is homeless, you get to find out that they're homeless, you may need to send them to social services or connect them with your focal point there. If someone is struggling with substance abuse, you may want to help connect them with a drug treatment program, whether that's SRC or the Great Commission or some other community agency that delivers those types of services. So just be aware of who your partners can potentially be and where can you make the appropriate referrals and where the resources lie, because you will find that as a physician, you may only be able to do so much. You may have your hands tied, but you have partners who can take that patient or that individual the rest of the way and help to give them what they need, so that hopefully when you see them again, they're not in as bad of a condition or they've had some levels of improvement. And then finally, while you may not be the person on the front line of creating policy, you may be the person that supports some kind of initiative that promotes and does the health education around whether it's nutrition, active transport, encouraging walking and biking, whether it's not smoking, not drinking alcohol in excess. Like, these may be policies and initiatives that you can get behind as the physician and encourage those types of behaviors. And don't underestimate your role as a healthcare worker. Bahamians in general have a lot of trust in their healthcare providers. And if they say, oh, the doctor say don't do this or don't do that, there are patients that really, really do take what you say very seriously, and you can have a really huge impact on the lives of the persons that you serve. And that's public health again, because they're going to go back home to their families, to their communities, and share what they've learned, and you can have that larger impact. If we do not take this health in all policies approach, however, we can expect to see increases in health inequities, meaning differences in health outcomes among vulnerable populations in particular. Think about whether there are differences with migrant populations versus residents of the country. Is there a difference between rural populations in the Family Islands and the population in New Providence? Is there a difference between health outcomes for persons with disabilities and persons who are able-bodied? Do they have access to the same resources? Can they get to a vaccination center even? So just think about what issues can be afoot if you do not take the health in all policies approach. Secondly, we're going to see an increase in the healthcare costs to serve people, because likely they're going to come into your doors being chronically ill or in advanced stages of disease that could have been prevented, not just with pharmaceuticals, but with other measures if we, again, worked with other sectors. Thirdly, we're going to see a reduction in labor productivity. Healthy bodies is what it takes to show up to work and do a good job. But if people are not well, they cannot be productive and they cannot live quality lives. And finally, the social and environmental impact of these health outcomes will continue to go unaddressed if we're only focusing on a person presenting with physical ailments or physical illnesses. We're missing the underlying factors, and that's really the core of what's driving some of these issues. So in conclusion, again, these social determinants are these areas where people come from, where they live, where they're born, where they work. These things are influenced by how much access to resources that they have or don't have. And it's not just global, but also national and local. And these determinants are not just health in nature or physical in nature, but they have economic, social, and environmental origins and linkages as well. So think about the fact that your work within the health sector depends not just on the decisions and policies within the health sector, but also beyond the health sector as well. So as physicians, it's important for you to build those relationships, build those partnerships, and try to find the health co-benefits in order to improve health equity. And finally, think about the fact that the decisions in every sector, as we saw on our SDG model with health in the middle and everything else surrounding it, every sector has an impact on human health. So it should matter to you if you hear your Minister of Environment say something that may have a health impact, or your Minister of Transportation says something that has a health impact. Remember that everything links back to health, and you are able to make an impact on population health and health equity by applying the Health in All Policies approach. So that's my presentation, and with how many minutes? 11 minutes on the clock. I'll take any questions that you may have.
If I may, who would you say are the main drivers of health policy in the Bahamas? Because I know culturally we like to speak up on Facebook, on social media, but when it comes to actually making things happen, we rarely see that policy-driven approach taking place. So who kind of does that, and in what settings does that occur?
So the health authorities of the country certainly is the Ministry of Health. And I can give the example of how during the height of the COVID-19 pandemic, of course, there were comments and things being made on social media. And that's something that, they may pay attention to see what's the general consensus or how are people responding. But really, their mandate is to look at the data, look at the numbers, look at what's happening in a population. So the epidemiological situation, how many new cases, how many hospitalizations, and make a decision on if we're going to improve this situation, these are the things we need to do, whether it is introducing a new cadre of health professionals to support the ones that are already here, or setting up a new modular unit, or doing more communications to help people understand the importance of social distancing. Their decision-making is based on the best evidence that they have access to and the expected outcomes of certain decisions that are going to ultimately improve the health implications or the health outcomes of the population. But as the health authority of the country, the Ministry of Health is the one that drives these health decision-making processes. Of course, in partnership or in collaboration, they may consult, let's say, the tourism sector to say, how many persons are you seeing bringing in? Or they may look at their data and say, there's X amount of imported cases. Now that means we need to think about which policies do we recommend to the Ministry of Tourism, or how many cases are we seeing coming from school-age children? Well, that may determine the policy or the recommendation that's put forth to the Ministry of Education to now improve the health outcomes for school-age children. But they are the health authorities of the country, and they would use their best data and evidence to support the policies and the decisions that are made.
All right, thank you. And I have one more question. I'm sorry.
No
are there
problem.
any avenues in PAHO for medical students to be involved? I know there was PAHO Youth for Health, but for a lot of us, we may not qualify because of age. So we're just looking for spaces that we can get involved at that level.
Yeah, PAHO has a internship program. I must say that is an unpaid internship program. However, once you reach out to express interest in whichever area you would like to work more in, we will take it on a case-by-case basis to kind of see what programs or projects we are currently undertaking in the country office. And if it is a good fit, then we would do our best to accommodate. So yes, there is an internship program through the organization.
Okay, thank you.
Mm-hmm. Any other questions in the remaining 6 minutes? Was everything clear in the presentation? Any new ideas that came up for you? Any new interests that you may be wanting to explore? Rolanda, Shaquan, Lincoln, I don't think I heard from you all today. Marissa, Andia, Jordan, you were the first one here.
I don't really have any questions at this time.
Okay, what was the most potent thing for you then? Takeaway.
I guess the most important thing is that I guess it's a lot of different factors, a lot of different organizations that influence the I guess the policies as well. It's not just one particular sector that deals with the policy making, but it's a whole different sectors as well that contribute to the overall policy.
Yeah, that's a good summary. Thank you.
Well, now that you brought up, I actually have a quick question. I recognize that recently research has shown that men are dying at a higher rate than women. So I'm curious, since PAHO has some connections with the World Health Organization and United Nations, and regarding the push towards human rights and equal rights and access to health care, I was wondering, what is the regional office currently doing to leverage men's health initiatives in the country?
We have worked in the past with the Ministry of Health, specifically on men's health, because we know that their health-seeking behavior is not the same as women. And so a lot of the initiatives, whether it is promotion of physical activity or encouraging them to get their blood pressure tested or their blood cholesterol tested, in a lot of the approaches that would otherwise be, I guess, population-based or open for anyone, there's a specific focus on targeting men. How do we bring them to the table? How do we encourage health-seeking behavior? So it is an ongoing, I would say, priority that we have along with the Ministry of Health to understand why men may not seek as much as women do, and how do we help to get them more into preventive ways of living on lifestyle practices, as well as getting the necessary treatments that they may need to manage their conditions. So I would certainly say it is a priority of the country office and the Ministry of Health to ensure that our approaches or our interventions consider how do we be inclusive of men and improving their health outcomes.
Thank you. I also want to ask, in your network, or I guess within the PAHO Association, have there been any programs regarding men's health that have shown some traction or some progress in getting some of that health-seeking behavior that you may know of?
Not that I can think of offhand. Doesn't mean it doesn't exist. Have you heard of the Healthy Bahamas Coalition? That may be something that you all want to research or do some more work on. But they have various committees that are focused on various health topics. But yeah, they also come up with some programs or projects, but I can't think of one right now that has been very popular, but it doesn't mean it hasn't been done in the past. It's just maybe not caught on as largely as some of the other interventions.
Thank you.
One more minute. One more question.
I'll just add to that, not to cut off the students.
Sure.
Right. Well, we have or the Ministry of Health has a men's health program under Nurse Chesmont Finley. And I know there's a male desk at, I don't know if it's in social services or another ministry where they look at more of the social issues to do with, men. And so I think they collaborate. Then there's a men's health clinic, when you're looking at the actual health care for men. They rotate throughout New Providence. And so there's a clinic at each one of the 3 polyclinics and then at South Beach Health Center. They rotate. So there's one male health clinic a week in somewhere in New Providence, whatever day it is at Flamingo, then Fleming. So, obviously trying to cover the population and give them some access. Men don't like to come to the doctor during the day, during work hours. So they may come later on, in the evening. So you have to think of that too. Because if you're a construction worker, you can't suddenly stop your work to say, I'm going for a checkup. And you have concrete or something, and that's the reality. You
or you only have a half hour.
Right, exactly. So we have to think in those ways too, and maybe go out to them in the barber shops, even the bars, where men hang out and sports.
The domino tree.
Pardon me?
The domino tree as well.
That's right. The basketball courts. That's where guys hang out, Church, even church, women and men go to church. So you can reach a whole lot of men at church too. And other things, service clubs and, other groups that men are in, all these regattas. That's where a lot of men go and you can do your STI, HIV, thing at places like that. Montague, the Exuma regattas, thousands of guys go down for those things, hang out and just, so there's hope. There are ways to reach them.
Yeah, I was having a conversation with a colleague in Turks and Caicos yesterday, and she was telling me one of the strategies she uses for men's health initiatives is that she sets up a domino table, maybe a backgammon table out on the park, and she say, come, let me take your blood pressure before you get your blood pressure worked up after you lose a game or something. Let me test your blood pressure. And then you go ahead and have some fun. So I think the point is sometimes people will not come to you for the services, and we have to be creative in going to them to deliver what they need.
That's true. Yeah, I like that approach. If you build it, they will come. That's what she said.
Yep.
That's a good one. Yeah, and then the other sort of thought I had was when you spoke about the migrant population, and I spoke to the students about persons from Haiti, the women from Haiti, who I think are an underserved group in particular. So I think in addition to the other social terms of health, I think we now have to add language, because, it's difficult to communicate health to somebody who is not speaking your language. So if you don't know Creole or Spanish, depending on who you're talking to, that's a barrier, unless you have someone interpreting there and all of that. So I just thought of that the other day. I said, wow, because we were speaking about what was our topic? Anyway, we were speaking about that and it came up.
Even for persons that are hard of hearing, we may need to put in the transcription, and that's
true.
Or have a live interpreter who does sign language for persons who just cannot hear very well. And sometimes it's not even intentional that we leave these persons out. But we have to be ahead of the game and think about who am I actually trying to reach? And if I'm gonna make a commercial or a PSA or something, did I put closed captions? Did I use colors that people can actually see? Did I put it in a large enough font for people to be able to read? And it's not always intentional.
Was the language simple enough?
Exactly.
Did I use a lot of medical jargon?
Yeah. So you all have a role in health literacy as well.
Yeah, health literacy, good, and health communication, public health communication. It's supposed to be at grade 6 levels, simple language and easy to understand.
Yeah.
So it's now 4 minutes after. I don't know if there are any other comments. I don't see
I don't
Mrs.
see
Nairn
her.
hasn't joined yet.
No.
Oh boy. Okay, well let me talk to her.
Okay. We can hang. Do you want me to hang around and chit chat a little bit longer until she
Sure, go
comes
on. Yes,
or-
I'll do that in a minute.
Okay. Okay.
So
Anything
much to
else?
talk about.
Yeah, it doesn't have to be health and all policies related. Let me ask, do you all kind of know what field you're thinking about going into or what specialty you may want to explore? Or you're still kind of on the fence and not yet decided?
I'm not sure exactly what I want to do, but I know that I don't want to deal with clinical medicine. So I'm looking more at the administration part of my degree.
Nice. You might want to consider public health administration. That is an actual thing.
I'm looking at that as well.
Awesome. Anyone else persuaded to the world of public health or at least thinking about it?
I'm trying to figure out a way to merge public health with a specific clinical aspect because I'm interested in neurology, but I'm also interested in public health and global health. But I also ultimately want to be Minister of Health, so I know I need those as well. So trying to figure out how do I marry all of my interests into one.
I would say think about what are the maybe risk factors or underlying factors that impact neurological issues or conditions. Where are the gaps in services, health services, as well as the gaps in policies that allow people to even, let's say, start with being screened for those conditions and then treated. Is it something that they have funding for or access to? There may be research projects that you want to undertake to better understand the burden of the issue in the country to generate more evidence. So there may be fellowship programs that you look up or internship programs that you look up that come with funding for you to do that kind of work. And then I'd also say get involved a little bit with health policy because a lot of, future Minister of Health, you will have to make some policy decisions. So it'd be good to have an understanding of the health sector at all of the tiers and how it works, like not just the health and all policies approach, but also the administrative side, the clinical side. It's all one comprehensive picture.
Yeah, that's very true. Thank you for that. If I were interested in getting some kind of exposure to health policy, what would you suggest I start?
In the Bahamas, I would say there may be, I'm not sure if they have done it before, but maybe you can ask to shadow or work along someone in the health policy and planning unit of the Ministry of Health, just to see what kind of work they do. And maybe you just offer yourself for one day out of the week or a couple of hours out of the week just to get exposure and work on a specific project that might be ongoing, just so you get the experience of what it is they do on a daily basis, sitting in some of those meetings and just have an idea of who are the players and what roles are they functioning in.
Okay, that's a great idea. Thank you so much.
Yes, good students. Okay. Mrs. Nairn, Delaval Nairn will join shortly. We still have a few more minutes with Ms. Jones.
Shaquan, let me hear from you.
Hey.
How are you?
I'm good.
Good. Any salient points came out of the discussion today or anything you're mulling over?
I just really like the point of I think it was a health and all policies approach.
Mhm.
I really liked how you tied in the Ministry of Health and Education, but not only those, the parents and the churches as well,
Mhm.
because although I know they contributed a lot during COVID, I never really kind of separated or looked at that in a deeper aspect.
Mhm.
And yeah, it was a really good presentation. In terms of my specialty, I was looking at surgery or intensive care.
Mhm.
I'm still on the fence about it, but I wanted to do something in a clinical setting.
Awesome. Awesome. Happy the presentation was helpful and wishing you well in whichever you decide on. What are the emerging public health issues that you all have been following besides COVID? Any other issues you've been following? Monkeypox? Anything else? Hey, Dr. Moxie, I'm hoping that this cohort would also get the exposure to the IHR and the immunization presentations.
Yes.
I think they'd be very relevant for, of course, COVID, but the other vaccine preventable diseases as well.
Reminds me, yeah, you mentioned the collaborative approach, and I was NCDs. I think I reflected a bit and I realized we're talking about the same thing, but this one is specific for NCDs, and it comes out of the Healthy Caribbean Coalition. And I think so it involves the business community, the civil society, and then government. And I think that's the approach we're gonna have to really get going on, to get results. As you were saying, the food stores, the on the business side, we don't manufacture that much food, but
No.
we had a big food manufacturing sector, they would be involved too, to reduce salt in the food, sugar in the food, those population-wide approaches.
Encouraging more agriculture.
Right, yes,
Yeah.
you need agriculture,
We spoke
that
about
approach.
taxation.
Pardon me?
We spoke about the taxation approach on
Right.
maybe things with high sugar content.
Right, yeah. Even fast foods, restaurants, it's so difficult because they really are controlled by external forces, so they just have to produce whatever is sent to them. So, they really can't Bahamianize their approach because they get a certain product and it's marketed and that's what you sell because you're part of a franchise. So
right.
That's difficult.
Yeah, I think we see, just like COVID, there's no one silver bullet that solves all of the problems, and more likely than not, it's going to be a multidisciplinary and multi-pronged approach to addressing these otherwise really complicated issues. So taxation alone won't do it. Education alone won't do it. So it's some sweet balance of a lot of different things, or a few things to make a dent. I see Miss Mullings has a hand up.
Yes, I just wanted to say one thing, what do you do in cases, right, where persons cannot even, they don't even have the time to think about the quality or the nutritional value of food because they probably don't have a job, or if they do have a job, it's not paying them enough. So I just feel as if what do you do in those cases where they really can't think about the nutritional value of food? They just want something or anything to eat. So what approach do you take there? Where I'm pretty sure they don't really care. Some people might not even care about eating an apple or a vegetable a day. They just want something to eat that's within their that's within the amount of money that they can actually spend. You know what I mean?
Yeah.
How do we approach, or is there even a way to approach situations like that, to be honest?
Yeah, that's a really good question. Back to what we were saying earlier, it's a mixture of things. So yes, we can start with education, meaning I teach you how to read a food label and understand what do we mean when we say sodium or MSG or sugar content is whatever grams or milligrams and how much you're supposed to have. So that's one approach. And then there's also the approach of, like you said, if I only have $5 and I need to make this stretch for dinner, what do I choose? And a lot of your purchasing power is going to be dependent on policies or taxation or any other high-level health sector policies that determine, firstly, what's available in my community. So if the corner shop does not have fruits and vegetables for me to even be able to consider purchasing, I'm already living in a food desert where there is not enough nutritional value for me to even have good health outcomes. So that's the first thing, is it available? And then the second thing is, if it is available, how affordable is it? So your policies or your interventions may think about, how do we get fresh produce to mom and pop stores, or, the corner grocery stores? How do we get that there? How do we even make sure that people want to buy healthy foods? Do they know the importance of it? And then how much does it cost? If the one banana costs me the whole $5, then I'm going to be inclined to go for the 5 cans of spaghetti that has so much sodium in it. So that's actually a part of what the bread basket revision was seeking to do, is, lift some of the economic burden of being able to access healthier food options and taking out some of the things that are not as healthy or nutritious. And so persons who may be on the end of, having economic difficulties making these kinds of decisions. I mean, really, the cost of food is going up in general, right? But at least for those persons that find themselves in that situation, they have a better chance, or they would fare better at making healthier decisions. And it's what we call in public health, making the healthier choice the easier choice. And that means improving affordability, improving accessibility, improving education, and hopefully a combination of those things would help persons to actually choose better and differently. And of course, there's this whole thing of human behavior as well that we have to understand. Sometimes food may be affordable and accessible, but there's also this individual factor to consider, that some people may still choose what's not healthy or what's not okay. So there's a whole social and behavioral science behind nutritional decisions as well. So that's why I said it's not just policy, it's and education. It's a combination of things to even understand why people choose what they choose, and how do we change their decision-making process, which is very hard. Human decision-making is a very hard thing to change.
Excellent.
I don't see Miss Nairn, and I don't want to take up too much time.
Well, I don't know what's gonna happen.
Yeah, I was really just holding on until she comes in.
Just continue then. Yeah, let me give her a call back. I hope she's not having a challenge with anything. Okay, I'll call her back.
Okay.
I expected her to be here by now. Okay. I spoke with her, but I'll call back. Thank you.
Okay. Do you all think you can be advocates for healthy behaviors, lifestyles, to really reduce risk factors of any disease, NCDs or otherwise? How can you be health advocates?
Advocates for healthy behaviors?
Mm-hmm.
But I think the most easiest role for us would be education. So making sure that we spread accurate information, especially because we're more of the technological inclined persons, to make sure that we have information that is true and accurate, and also correct people when we see mistruths. Because we know during the pandemic, it was a big issue with all the myths that were fluctuating. So I think that's the easiest role that we can get into. Also, we can be activists in our community. So just try to make small changes in culture, whether it be in our homes in that small microcosm, or even at a larger area, like with our youth groups, our churches, wherever scope we have impact and influence. I think that would help us to make change. Yeah.
Wow, absolutely. Those are all really good. What are your sources of information? As you mentioned, the issue of misinformation during the pandemic. What are your sources of credible information?
Well, the gold standard is always WHO and PAHO. You start there. I try not to look at media houses because I understand that a lot of times their messaging is skewed based on who they're trying to reach or the message that they're trying to send. So most of the times it's semantics. And then there's a lot of credible journals that actually do research, Medscape, a lot of publications that come out based on topics. I try to use that to guide my knowledge as opposed to just listening to what I see or hear on traditional media.
Yeah, if you could, I would encourage you to subscribe to journals like The Lancet. There are a number of public health journals, just so you could kind of see what new literature is coming out, and you're able to, you know, speak to what recent research studies are showing. But, you know, sometimes we give the media a bad rep, and I think it's an opportunity for us to partner with them. At least that's something that we try to do, is work with them to shape public health messages and not sensationalize them. Because the way that they report things can invoke fear, can be a little misleading, or can sensationalize things. But there are opportunities for you to work with them, whether it's getting an interview on a radio segment, or like a Ask the Doctor segment, or doing some sort of a TV interview for raising awareness of, let's say, World Diabetes Day or World Hypertension Day. Those are all opportunities that you could leverage your voice at a national level to be an advocate for a healthy lifestyle and behavioral changes, as well as, I'm assuming we're all young in the room, so we all probably have some access to social media, and that's where a lot of persons are getting their news from. So again, that can be a space of either sharing some of the articles that you come across, could be on LinkedIn, Facebook, Instagram. All of these are ways that you can formally or informally engage various communities of people.
That's a good idea. We had a medical association. So one of the things we did is during the pandemic, because everybody was on lockdown, we did social media campaigns. So where we would actually make material and send it out. And then we also did lives where we would feature persons that people would respect, like Nakia Forbes, and give like a youth perspective to that. Even one point we went on a radio show, we went on a Hit Back with Nahaja Black, spoke about like the medical school perspective, because we were torn in between the clinician and the average person. So I think persons like that vantage points of seeing that, okay, this is somebody I possibly could relate to, because they kind of straddle the fence. They're not heavily in medicine to feel like they're tainted or influenced, but then they're also still a lay person as well. So I think that was a unique opportunity as well.
Awesome.
Yes, I was gonna add to Fernand about the show that Dr. Denotra Archer has a show. We actually have a physician who has her own show. I think it's Dr. Archer. I don't know if you all listen to her.
Do you know what radio station she's on?
No, I'm not sure which one.
Okay, I'll ask. Thank you.
But she has her own show, you know. And it's an interesting show. I'll just put it like that. It's not always pure mainline. Well, I think we could talk about a show, you know. Not always pure mainline medicine. It's interesting. Let me stop it at that because we're recording. But yeah, but you're right. You know, physicians are using the media, and I think because of COVID, you know, it was very became, there was a lot of controversial areas. And so physicians sort of took various positions, and I think coming out of that, some went on to have their own shows and appeared on different shows. And so it was quite a debate, even within the physician community, about what to do with certain medications, like, first of all, it was hydroxychloroquine, then it was ivermectin, and then it was the vaccine, not a medication, of course, but the vaccine, whether it was safe. And, as I said, even with the doctors in the physician community, doctors were debating, and the Medical Association formed a WhatsApp group where it was primarily to communicate current, health policies and to the primary care doctors. And the group comprises about over 100 doctors. We still have it going. And, we've debating some other things or discussing some other things in the group now. COVID, of course, still is the main purpose. So we still have that as our focal point, but other things. So, there's a little more time now for other things. So we branch off a little bit. And we put in CMEs, current CMEs or upcoming CMEs into the group. And people, it's really helped us, to be honest, to stay current. Because so much went online now that literally, you can go to a CME almost every day of the week. Somebody's teaching something. So really push the knowledge base, much higher. Because you have so much access now to really good teaching online. So there's been a shift in that regard. So it helps our competence, to be, to be able to go to all these, to be in all these CMEs.
Yeah, I think it just underscores the fact that health in general is an ever evolving field. So it's public health, meaning there's always new things to keep up with, new or emergent diseases, things that happen in other countries that will have implications for our country. And we spoke a little bit about globalization earlier, meaning things like travel and trade, migration, all have implications for us. Something that happens in Europe can very well become our problem in a matter of hours. Just look at how quickly COVID-19 became a pandemic. I think it was January 9th or so where the first announcement of a new virus being on the horizon was made. And then just a few short weeks later in March, it was at the level of a pandemic, a public health emergency of international concern. So things can change very quickly, meaning, especially as a touristic country where we have millions of persons coming in on any given year from every corner of the earth, a situation in India, in Taiwan, in wherever corner of the world can quickly become an issue for us. So be on top of and aware of what sorts of issues are happening in the global landscape so that you're able to prepare for and not be in a panic state where you're trying to respond to. And that's a part of health policy as well. Like in the event of this situation, this is what we're going to do. And of course, sometimes things happen and you didn't have a chance to follow your SOPs, or, maybe there were some gaps in your SOPs because lived experience is different from what's written on paper. But the idea is to be on top of it and use the evidence that you have, the data that you have, and your awareness of what's happening on the local and global stage to better prepare for and respond to any issue, whether it's COVID, whether it's monkeypox, whatever it is, just to be best positioned.
Yes, very good.
Were you able to get Camille?
No, yes, I did. She had to switch laptops.
Oh, goodness gracious.
Yeah. It's okay. I mean, if she doesn't come on, we'll continue. And then if you have a little more time, and then I guess we'll stop at it soon. You know, because I know you have to get on with your day.
Yeah.
PA till 10:30.
No,
I did tell you 10. No,
yeah.
actually, no. Originally we said 10:30. Then I wrote you back to say 10 because Camille was to start at 10. So
right. No worries.
So, yeah, I know you have stuff to do.
Yeah. So I don't know if anyone has any final questions or things they want to say or anything. Miss Mullings.
Sorry, I don't know if I did. Oh, sorry.
Go on, Miss Mullings.
No, because my internet was freaking. It wasn't working earlier. But I just had a really quick question. Do you guys like work along with like the hospitals as well?
Yes. So that is a part of our, well, under the remit of the Ministry of Health, specifically DPH. All of the clinics come under them. And then, of course, the Public Hospitals Authority, the Rand Memorial Hospital, the clinics in Grand Bahama, and of course, PMH, SRC here, and all of the local clinics. So yes, we have a number of projects actually in collaboration with those health agencies. I don't know if you had a more specific point or a question, but yes, we do.
No, I guess wanted to know, like, do you guys like work like personally with, I guess, like the cafeteria, like on their staff, and how like food is distributed to the patients as well?
Oh, no, okay. Not to that level. Okay. But if you're interested in the topic of food safety, I would say that that is something that we've, done the production of like technical guidelines or considerations for food safety. So that's an area of interest for the country office. But we don't work specifically with the workers and staff there.
Okay, no problem. Thank you so much.
Well, I had fun hanging out with you all and chit-chatting. I hope that today's session was useful, that you have a new perspective on how do you approach public health and as well as clinical health and just the interconnectedness of all of it. So I wish you well on your journey, and hopefully I will be able to see you all walk across the stage again like your colleagues did yesterday. Hang in there. I know sometimes it gets a little bit rough, but you've made it this far, and that means you have what it takes to take it to the finish line. So I'm looking forward to celebrating that milestone with all of you and seeing how you flourish in your professional careers. And perfect timing, Miss Nairn just entered the room. So with that, I bid you all a good day.
Great. So thank you very much, Ms. Jones. You were excellent and most important presentation, discussion.
Yeah, thank you all so much.
Thanks. We'll be in touch.
All righty,
right.
bye-bye.
So let me know what Dr. Basson says, please.
Okay, no worries.
I appreciate that. Thank you.
Okay, take care, everyone.
Day. Okay, you too. Bye-bye.
Okay, bye-bye.
Right. So good morning again, Mrs. Nairn. So good to have you on board. How was everything? Hello, Mrs. Nairn.
Good morning. Good morning, everyone.
Yes. Good morning and welcome.
Thank you so much.
I know we have limited time. So what I'm thinking, if you don't finish everything, I don't know if you'll have some time later on today. After lunch, we have a gap that could be used for you to finish at about 2. I don't know if you have other appointments already. Or let's see, even earlier, you said you have an 11 to what? Your meeting is an hour and a half?
Yes, it probably runs until about 11.
Until about 12:30?
Yeah.
Okay, so are you free at 2 to come back, or do you have a gap there? Okay, awesome. So if you get started, we won't kidnap you and prevent you from going to your meeting.
Okay, well, I already gave my apologies.
That's okay. The students enjoyed a really rich discussion with Miss Jones in the, as you were preparing.
Okay,
So I think if you introduce yourself and get something completed, and then leave, then we could reconvene at 2
okay, sure.
to finish your presentation.
Okay.
So students, this is Mrs. Camille Delavonian from Health Information Unit at the Ministry of Health on Meeting Street. That's where she sits. So she will introduce herself. Sorry, I don't have a proper CV. And then get her talk started, with regard to health information. Thank you.
So good morning, everyone. And my apologies once again for starting late. I had some difficulty connecting.
Yes. Can they see you, or?
Sure, I was quite prepared.
With the video?
Yeah, let me just.
I find it's more interactive when the students can actually see the presenter.
Okay.
Thank you. And then you could start screen sharing as soon as you're ready. Thank you.
I wanted to hide my junkie office.
Sorry, I didn't hear?
I wanted to hide my junkie office.
Highlight.
Hide my junkie office.
Oh, no. I know. People are rating everybody's background. Oh, that's so fabulous. And I know what you mean.
I haven't.
Those
fancy things.
I know. Some of them go all out now with their bookcase and their object art, these art objects and paintings. And
Okay,
that's okay. It's what's being transmitted is important, not the beautiful background.
Can you see? You can see me.
Yes.
Okay. Let me just.
If you bring your camera down a little bit, you're actually cut off at the right. That's better. Yeah, you're more centered now. Beautiful. Okay.
Thank you.
Sure.
I'll share my screen now.
Okay, great. Thank you.
So hi everyone. I feel like
we're recording also, Mrs. Nairn, if you don't mind.
Fine.
Okay, thank you.
So good morning once again, everyone. I feel like I'm at a disadvantage here because I can't see you, but how many persons are there? How many students?
We should have 13 students in the group.
13, okay.
Yes.
Great, so it's nice to be here with you this morning. And as Dr. Moxie would have told you, I'm in the Health Information and Research Unit. Here at the Ministry of Health, we've been around for some time. I've been in the ministry since, I think it's 1989. So stats is basically all I've been doing here at the ministry. Everything related to the collection and analysis and processing of health information. That is what this unit is all about. And the mission, as you will see, is to coordinate and serve in the planning process, implementation, and operation of the health system. And that work involves collecting, processing, compiling, analyzing, and dissemination of statistical information about the health services and health situation in the Bahamas. And so one of our primary functions is to provide health planners, administrators, and others with the necessary information that they need to make evidence-based decisions. And we hear that quite a bit. It shouldn't be made, on a whim, but it should be supported by real evidence. And one of our functions also is to strengthen the access to information to ensure that we have quality information that is produced and to strengthen the use of information that is required at all levels in the health system. We also provide statistical consultation for special projects. We're usually a part of exercises going on here in the ministry, as well as with the Department of Statistics, well, which is now called the Bahamas National Statistical Institute as of July 2021. And so for their national projects, we are involved with some of them, like the census, for example. One of our other responsibilities is to serve as a liaison on statistical information matters with other departments or organizations. So agencies needing information from us quite often would route their requests to this unit. And also if there are persons here in the ministry who need information that is outside our agency, we would act as a liaison for that as well. And we respond to information requests that come in from external agencies, regional bodies, students, not government, as well as non-government agencies. The sources of data, I must say here that we don't generate the data ourselves, but what we process actually comes from elsewhere. So you can think of us as being a sort of data warehouse. We have information coming in from the hospitals, from the clinics, from the Bahamas National Statistical Institute, as I will show you shortly. And we have other stakeholders as well who send their information to us. So all of that is processed and analyzed on our end. So one of the sources of data, as I said, is from the hospitals, and that relates to inpatient, both public and private. And we have 2 public hospitals, actually 3. We have PMH, the RAND, as well as Sandilands Rehabilitation Center. And they have 2 main hospitals, sub-hospitals, which are the geriatrics area, as well as the adolescent ward. What is it called? The name is running away from me, but the psychiatric division, and then we have the geriatric division as well. So those are public and the public hospitals, and then we have the private ones, which are Doctors Hospital. There's Sunrise Medical in Grand Bahama. The Lyford Key Hospital don't offer the full services of a general hospital like Doctors, for example, but they're one of the private facilities that we include in our counts as well. Then there are the outpatient data from the Accident and Emergency Department, and there's GPC, General Practice Clinic, and the Specialty Clinic. Not so much from those areas at the moment, but with the strengthening of staff, we've had more support coming in, so we should get more data. And then another area is community health services, from where we get the clinic data. We have about almost 70 clinics, community health clinics spread out across the Bahamas. All of them are not your main clinic like Flamingo Gardens, for example, or Elizabeth Estates Clinic. Some of them are called satellite clinics, and the satellite clinics are those clinics which are run in a non-clinic facility. So it could be in a church or a schoolroom, whatever is available, where the medical personnel can meet to offer the service to persons in the community. So we have clinic data, there's infectious disease surveillance. We have a surveillance unit, which is not housed in the building where we are, but they're actually on not Meeting Street. We're on Meeting Street. They're on Rosetta Street, which is in the Palmdale area. And then there's some special surveillance. Special surveillance would be covered under the surveillance unit. And that's because, with with infectious diseases, there are things that come up from time to time. For example, COVID-19. And for that, the team in the surveillance unit was extremely busy, and they also had to become more reinforced with additional staff and help to actually meet the needs that arose as a result of the pandemic that we are still in. Then there are special registries like HIV and AIDS, which is, it was actually run by this unit, but it's now housed under the National AIDS Program. So there's now an epidemiologist who has that as part of her portfolio. And she was very instrumental in the COVID-19 response as well. And there's a National Cancer Registry, as well as the Hospital Cancer Registry. So there are two. The National Cancer Registry was actually established in 2018 by law. And so it's now mandatory for new cancer cases to be reported to the National Cancer Registry. As far as compliance goes, well, that's another matter. There has to be follow-up. You know, it's not just passive surveillance going on here, but the manager there has to actually follow up with the private sector to ensure that they report those cases. As regards cancer as well, some cases are, you know, some persons go abroad for treatment, but that's another catchment that they're still working on trying to get handle on what the volume is like. But of course, we feel assured that most of the cancer cases are actually recorded here in the Bahamas. Then there is what we call SIP. It's a Spanish acronym for the Perinatal Information System, developed by one of the PAHO offices. And it is for maternal and child health. So it captures data related to the pregnant woman, the actual delivery outcomes, and the outcome of the baby. So that's a very rich data set that is available as well and maintained over in the maternity ward over at the Princess Margaret Hospital. The Rand Memorial Hospital also uses it. But I must just pause here to say that we have to get an upgrade because the SIP system is currently a standalone system, and we have learned that there is an integrated version available, and so this is what we intend to acquire for our site so that everybody can log on online and then update the information for their patients, and then that information can be reviewed at a central level from the Ministry of Health. So that's something that we are looking forward to in the very near future. So another area is vital statistics, which involves live births, stillbirths, and deaths. So these are I would say the key sets of information we get from them. Those are key statistics, and then there are also labor force and economic data as well. And here I should also mention that well, as you know, births and deaths have to be registered, as well as stillbirths. However, there has been a degree of under-registration that has been taking place over the years. So it's been more than 20 years, perhaps, since this unit was charged with actually getting a census of these events from the institutions where these events occur, like from the hospitals, from the birthing centers. We would get this information from them and then compile it once it's all completed and vetted. Then we would share it with the Department of Statistics. I'm interchanging the name, but you're following me, I'm sure. The National Statistical Institute. And then they would then report the figures and include them in what they're doing. So we have a close collaboration in that regard as well. And I mentioned these institutions where the live births and deaths occur. And some of these events occur in the family islands as well. So the clinic nurses would send us their monthly reports. Unfortunately, I don't have a copy, a snapshot to show you at the moment, but I can always email it to Dr. Moxie for you. And then there's the Registrar General's Department. We are trying very hard to reestablish a link there. There is a link. It's just not active right now between this unit and the Registrar General's Department. So we are trying to reestablish that link because they are very critical in the data flow, in that flow of mortality data coming from the institutions. And so wherever there is a weak link, that could cause everything to come to a halt. And we have had, I would say, we've had a backlog really in the coding of deaths. For every death that occurs, there is a code that has to be applied to the cause. And I don't know if you're familiar with the International Classification of Diseases. It was developed by the World Health Organization. So Dr. Moxie, I hope you'll talk to them about that.
Yes, they've gotten a little exposure when they did the natural history of disease.
Yes.
Spoke about the International Classification of Disease,
Okay.
ICD-10. And they know they have access to it at ICD10data.com. You know, everything is coded.
Yes.
I think I told you this last time we spoke. Yes.
Okay.
ICD10data.com. They can use that to get their codes.
Okay, so each class is exposed to the same information?
Yes, basically, yes, they get that lecture. That's a standard lecture.
Okay, great. Thank you.
Yes, thank you too.
Yes. And these are the other collaborating agencies, the Public Hospitals Authority, the Pan American Health Organization, and UWI, and of course, the University of the Bahamas. So these are other agencies as well. So in a snapshot, this is what it looks like. And you see the bidirectional arrows, meaning we get information from them. We also communicate and disseminate information to those agencies as well and units. So here is just, this slide is meant to show you various indicator frameworks. Indicators give us information about certain health, how should I say? These are statistics about various aspects of health. And for example, infant mortality rate, that you would consider that to be an indicator. So we have to provide the statistics for it and many others like it. I don't have anything on my computer right now to show you, but I can also send you examples of that. At the moment, there is a committee that has been doing some work. It's the Information Systems for Health. And so as part of a project that I've been involved with on a subcommittee is to gather all indicators that the ministry has to report on related to health. And we have to report on indicators to various agencies, to the World Health Organization, to the Pan American Health Organization. There's also been UNICEF and others, as you will see here. And then the WHO has various indicator frameworks that we have to comply with. There's tobacco, there's tuberculosis, there's MCH, maternal and child health. But then from time to time, we get something coming from CARICOM. So there are numerous ones, and so probably agree that you see the logic here in having everything in one place so that we'll know who we have to report to and what we have to report on, and what frequency it should be reported on. That would help us to be more organized. So that's a whole other area that the ministry has been working on. And so this is just a snapshot of different sites. Well, you're well acquainted with PMH and its sites. There's the RAND as well. And let's see, this is the PHA over here in Centerville, the RAND in Grand Bahama. And then there's Sandilands and the rehabilitation services area as well. And this is where we are here at the Ministry of Health on Meeting Street. We've had a lot of requests from students, but there actually are diverse users. And we have a web page. I will give you the address. It does need to be updated. So that's something that we have to work on. So just in brief, we have just under 500,000 visits per year. This is the average that we've been observing and the latest I can share with you at the moment is up to 2018, 463,000. And these are the various clinic services that are offered. There are others, like dental health, for example, but these are antenatal care, postnatal, child health, school health, other clinic services, and other home visits. That's the last area. So the other clinic visits, that's the biggest catchment area that we've seen. And that's where we have patients from about 15 years and older. And so chronic patients are seen here for coming in for diabetes and hypertension. And then we have school health and the others. But this is the biggest area we've seen right here. And in the other clinic visits, I'm just looking back here for this group right here, other clinic visits. I'll just show you a breakdown of that. Okay, so for 2018, there were 39,000, almost 40,000 visits for persons with hypertension. This also includes repeat visits. So all of them are here. So you can see public health is a very busy area. And then next we had persons coming in for respiratory system diseases, another 18,000, musculoskeletal system and connective tissue diseases. And then further down we have diabetes and genital urinary diseases. So this is just to give you a snapshot as to the number of visits for specific purposes. And what's coming up next are results from surveys that were done in the past. This one is rather dated, but we don't have anything more recent. This is the national survey that was conducted by the Department of Statistics. And because they're so expensive, it's a huge undertaking. They could only be done like every 5 years. And you see, it's more than 5 years now. So we've not had one since 2013.
Oh, excuse me, Mrs. Delavo, it's 11:02.
Okay.
Are you switching over to your other meeting? Or?
Well, I'll just go on for another.
Mrs. Nairn, sorry.
That's fine. I will go on for another maybe 5 minutes. I already gave my excuses. I had already informed them that I would be a little late.
Okay then. Okay. Thank you.
You're welcome. Yes, and so before this survey, there was a Bahamas Living Conditions Survey that was conducted in 2001. So we were able to get similar information at that time. And that exercise was supposed to be also done every 5 to 10 years, but we've not. The next exercise was done in 2013. So that gives you an idea of how much it takes to actually conduct a survey of this magnitude. So anyway, we had a health module in the expenditure survey, and they were only looking at expenditure in the population. So that's where we found that 16.9% or 17% of persons visited an outpatient facility in the past month, and about 4% were admitted to hospital in the last 12 months. And basically, this is what persons spent on average. It's dated, but it still gives us some idea as to what people are spending. We've had some challenges I mentioned earlier with regard to mortality coding. The same exists for morbidity coding. So in the hospital at PMH, I think it's partly due well, we know it's really largely due to staffing limitations. So, staff attrition. And so the volume is very high in terms of the number of patients. You saw how many visits they have in the public health clinics, just under 500,000. For PMH, it's, I would say, probably more when you look at all of the departments. But for inpatients, this is just to give you an idea. Some things would probably remain the same, like the top leading, probably top 5 would probably remain the same, like pregnancies and injuries. We've heard a lot about injuries in the news. I mean, the newspaper, when you hear about gunshots and such, we don't even hear about all of the cases of injuries that are happening. But external causes, they drive up the number of inpatients that we see in the hospital. And then conditions related to the perinatal period around pregnancy and delivery. And then the infectious diseases are coming in here, influenza and pneumonia. This would be higher, I think, especially in the last 2 years, given the impact of COVID-19, then hypertensive diseases and diabetes. I do believe HIV would have a much lower ranking, given the effectiveness of the program. And the trend here, we see that injury would take precedence. At that time, it would be interesting to see how things are looking. Right now, we have a team. The coding team has been strengthened with additional persons. So we hope to see the outcome of their work in the next few months, probably by the end of the year, early 2023, because it's a lot of coding that has to be done. So we are really happy about the reinforcement and additional staff to help with this work. So this gives you an idea of the mortality trend. Heart disease, again, is number 1, followed by cancer and external causes. Those are the top 3 main causes of mortality in the Bahamas. And then we have cerebrovascular disease, which is true. And the red one is, sorry, this is diabetes. And then we have HIV and AIDS. And you can see how the rates have gone down tremendously in the last decade or so. The program has been very effective, and they've had a lot of campaigns. They do outreach. So we can see the results of all of that effort to bring the rates down. people are living longer with HIV and AIDS. And so this is what a trend looks like for males. Heart disease is still out there, followed by external causes this time, and cancer. For females, it looks similar for heart disease. So, we have a problem with obesity and non-chronic diseases, non-communicable diseases. Those NCDs, non-communicable diseases, include heart disease, stroke, cancer, diabetes. That's some, as well as cerebral vascular disease. They are some of the conditions that we are trying to manage here in the Bahamas. It's our reality. And so for females, cancer is next, which is driven primarily by breast cancer. And just by the way, the main cancers that we see are breast cancer for females, prostate cancer for males. And I think the third one in the general population is colon cancer. Okay, so you saw those broad groupings just now. We also look at them in more detail. So number one, when we break down heart diseases, number one is ischemic heart diseases. And that's where heart attacks would fall in that group right there, followed by hypertensive diseases, which would be high blood pressure, that would be in that grouping right there. And then we have cerebral vascular diseases, which include strokes, and then assaults. From year to year, the ranking may shift depending on what's going on in our society. Assaults tend to go up. It fluctuates, and so we may see a change in later years. Diabetes, it's pretty much around number 5, and as we'll see a different profile for the more recent years because of the COVID-19 experience. This one is particularly for males, and assault is number 1. That's homicides, then heart diseases, hypertension, the NCDs would follow them. And then for females, it's hypertensive diseases, ischemic heart diseases, stroke, and then female breast cancer and diabetes. So this represents live births and infant deaths up to 2019. Live births being the dark blue line, and infant deaths the other aqua looking line. I'm not sure the colors come through on your side. But just to let you know that we've been observing this declining pattern in live births. So it's something that we have to look at more closely to ensure that we are indeed capturing all of the events. That's something that we have to do, just to be sure that what we are reporting is actually what's going on, is reflective of reality. But we've been seeing this declining trend, even with registered events, and what has been reported otherwise through our census. And here we have birth rates among adolescents, and 15 to 19 is the one on top. The 15 to 19-year-olds have had higher rates, but they have also been declining. And even though they have been dropping, it's still a concern in the maternal and the child health program. And there are lots of programs in the Ministry of Health. So I'm sure you've heard from some of them already. The maternal and child health is an area that we work with closely as well, because we have to collect information on live births, infant deaths, stillbirths, as well as maternal deaths. So it's a lot of going back and forth and making sure that the figures are all harmonized and in agreement. So we're also in touch with the medical records unit in the hospital as part of this process. There's also a committee that meets to ensure that we are maintaining communication and that everybody's doing what they need to do to make sure that we get the figures on time. So we've had some challenges, but I find that the communication meetings work well to, you know, keep everybody on track. So that's something else, you know, that we are trying to keep together as well. And here we have maternal deaths. This one is based on registered events. So we have registered events, and then we have also events reported through the program, through the maternal and the child health program. So those numbers are not here, but we have figures up to 2020 or 2021. But I think that figure for I believe it was last year, was 9. I think there were 9 deaths. And of course, that was also impacted by the pandemic. And HIV and AIDS, you would get from the HIV AIDS program. I can share the fact sheet if you don't have it. And I don't think, let me see, I don't think that's going to open up. No, sorry, I'll have to send that to you, Dr. Moxie. And I will bypass this one because we've just conducted, well, not just, but that was in 2019, a STEPS survey was conducted. And so there is a summary sheet. I'll just make a note to send that to you as well. Okay, so I'll leave this one out. And drug use, this is from secondary school surveys done periodically, and the last one was done in 2011. So this just shows the results of the survey, which shows alcohol to be the main drug of choice, followed by marijuana. And then there were other questions related to mental health. So they were asked about abuse, various types of abuse that they may have experienced, forced sex, and affiliation with violent groups or gangs. Right? That is what we are referring to there by violent groups. So about 12% said that they were affiliated with a gang. And then there are some concerns with abuse. And so this looks at tobacco smoking. This survey was conducted in 2017. And 11% reported, 11% of males, about 12% of males reported tobacco smoking in the past month, and overall about 7%. With regard to alcohol consumption, current smoking, 51.7% were current smokers, and current drinkers, and most of them reported drinking on the weekends. Marijuana use, to a lesser extent, about 3% reported using marijuana in the past month. And there was another school survey, the Global School Health Survey. This is another survey that is standardized. The STEPS survey is as well. It was, this one, as well as the STEPS, was developed by the World Health Organization. And all of the tools, the questionnaires, the methodology is shared with participating countries. And so we follow the same pattern so that the results could be compared across countries. And so this was focused on 13 to 15-year-old students. And so this is the nutritional aspect, where we saw that 21% was obese, 5% overweight, and 3.2% were underweight. here we looked at blood pressure readings, fasting blood glucose, because, I mean, we know that we have a problem in the adult population, so we have to look at what's going on with the younger people as well. But here, this one relates to, oh, this is the STEP survey from 2012. I'll share the other one. Again, on young people, these are persons who considered attempting suicide. So 19% seriously considered attempting suicide. 14% attempted it at least once. And 10% overall said that they had no close friends. So that gives some indication of probably depressed feelings as well. With regard to violence, sorry, these are trends over the period leading up to 2017. And we see that assaults were highest among cases that we're seeing. Road traffic accidents these were the two main causes for hospital admissions, and to a lesser extent, gunshot wounds and stabs and rape. And we spoke about suicide. So these are the mortality rates over various periods of time. And looking at the period 2012 to 2014, the rate was 3.6. This one relates again to young people. The percent who were in a physical fight or were injured at some point or bullied. Quite a number were seriously injured at least once. 23% in a physical fight. And about 7% bullied at least one day. So I'm pretty much near the end at this point. These are reports that have been generated. And the projects that we've been involved in. So all of these are available here. So if anybody's interested in further information about any of them, of course, you can feel free to let us know. And committees. And that's the staff complement at the moment. We've had some attrition in staff, so we'll need to get some additional persons very soon, because it's a lot. There's a lot of work to be done, as you, I hope you would have seen, in order to liaise with all of our partners, to carry out all of the functions. We definitely need more hands on deck, more technical staff, but we are indeed very, very grateful for the hardworking officers who are here, working along with me, Dorette Rowe, Sophia Bethel, and Maisie Miller. So that brings me to the end. Do you have any questions about anything I've said?
Thank you for the presentation. I have one question. I know you had mentioned there's a location that we can find most of the data. Where is that, you said?
Oh, here in the Health Information and Research Unit, we're located on Meeting Street in the Ministry of Health.
Okay, so what's the process if you wanted to find out about a specific disease process that may be happening in the Bahamas, or if you're interested in trying to find some data around something that we want to research?
You can just send me an email. I will, let me see if I can get to the chat and I'll put it there now.
Okay, thank you so much.
You're welcome. Thank you for the question. This is my email address. And then the web address is, you can check there as well. Okay, so that's the web address where we have some statistics posted, and we do have to post the updates that are available now. We have mortality data now up to 2015. And so when we get, I didn't mention earlier that we are currently involved in a, excuse me, in a mortality coding project. And so we have a team that got together over a couple of months last year to actually code the backlog of records that we had. And so once that was finished, that was phase one. Phase two now is to collate everything by year and then send that information on to the Caribbean Epidemiology. CARPHA. CARPHA is a Caribbean public health agency. So they do the high-level consistency checks, and then would share that data set with the Pan American Health Organization as well as the World Health Organization, because they use our data to do estimates, modeling, and a lot of other statistical routines they do. So there are several steps involved. Once we get the data set, it goes on and it is used at many different levels. So once we get some more mortality data available, they will be posted. The reports will be done and then posted online. But we have some staffing challenges all around, not only in this unit, but others as well, and other units that are really, really critical to the data flow as well as the data reporting process. But we do the best we can.
Yes, ma'am. Thank you so much for that.
Yeah, so just send me an email, let me know, and then I'll respond. If you don't see it online, then I will send you what we have available.
All right. Thank you. I really appreciate that.
You're welcome.
I have a comment, Mrs. Nairn. While the students think about their questions, can you delineate how a STEP survey is done? I speak to them about that basically, all the time. Yeah. That's one of our main, reports that we have. And I guess speak to the trends. What's happening with the students is that they're doing a project or research paper on diabetes, knowledge, attitudes, and practices. And I would want them maybe to include some of that information, either in their discussion or their literature review. They basically pass the literature review.
Okay.
If you could introduce some of the local data for NCDs,
Yes.
Please.
Okay, so the steps, as I mentioned before, it's a standardized survey developed by the World Health Organization for all countries. So it's one of those global surveys. So the Bahamas has been doing it since even before 2005. And what it involves, the acronym STEPS really stands for, it's a stepwise approach to conducting the survey. So there's a questionnaire that has various modules. It asks about tobacco, smoking, general health and demographics of course. Then we have tobacco smoking. It looks at lifestyle, concerns like alcohol use, tobacco use. It doesn't go into illicit drug use, but then it asks about risk factors for non-communicable diseases. The risk factors like physical activity or no physical activity, whether or not they, so exercise is a key part. So we ask the questions. So there's a lot of questions that are asked. First of all, so that's phase 1 or step 1. And step 2 looks at measurements. So step 2 involves actual measurements of blood pressure. And this is where we determine whether or not they have high blood pressure or normal blood pressure, as the case may be. And then step 3, in addition to blood pressure, what is also measured would be height and weight, because that's how BMI is calculated. Then following that, we have step 3, which involves the actual physical, the samples of the blood. So we look at blood glucose, total cholesterol, as well as the last time when the survey was done, they also looked at urine composition for salt intake. So that was something new that was added the last time. So they're the 3 steps that make up the STEPS survey. And so there are certain protocols that are followed to execute, especially steps 2 and 3, because, you know, the same way you would do it in a clinic setting, taking weight and height with the scales, everything has to be calibrated. There are protocols that are standardized that the enumerators would have to follow. And so we're actually working on the report now. There's a draft that has not been circulated as yet, but we are really trying to push to get the report completed and published. So as soon as that has been made available, I will let you know, Dr. Moxie, so that you can share it with the students.
Yes,
there is a preliminary summary that was done. I can share that with you.
Okay, excellent.
Yeah.
One other question about the methodology that the students may find interesting is, how do you get your sample and how do you select the islands you're going to survey, and, you know, a little more of that side of the thing?
Yeah, so that part is where we lean very heavily on our partner, the Department of Statistics, or the BNSI. And so the demographer over there is the person that we rely on to help us with the sampling. So it's there are multi-layers in the sampling process, because first of all, we have to select the islands and then the enumeration districts in those islands, and then the households, because it's not a door-to-door like the census is. With the census that is currently going on, we're supposed to go to every single dwelling in the Bahamas and get information about every person in those dwellings. But this is different. It's a sample, so in the households that are selected, we would select one person who is within the age group that we are looking for. And I think it's 18 to 25 to 64, or 2012. Forgive me, I'm getting the age groups mixed up. I'm not sure if it started at age 18 or age 25.
Oh.
I think, but once one person in that age group is selected from the household, and that's how it's done for each household that is selected. Did I answer your question?
Yes, the islands are, because, you know, I found it interesting that obviously you don't sample all of the islands, or you don't go to all of the islands, I guess, because of the cost, or maybe you don't need it. It's representative islands, but You know, do you find differences between islands? You know, maybe more fluent islands versus. I'm just curious, you know,
Well,
because we don't get much of the local data, you know, coming out. It's more national level, so you don't get to, you know, the finesse, the regional thing, I guess you could say, like, you know, you get in the US, you know.
right, right. So because most of the population resides in New Providence and Grand Bahama, they're always included.
Definitely,
So
yeah.
New Providence and Grand Bahama are regarded informally as the urban area of the Bahamas.
Yeah.
It is said that in Grand Bahama there are some areas that could be considered rural. I've not seen it myself. I've not seen those areas in Grand Bahama personally, but I know that there are some that are regarded as such. And but just for our working definition, we use those two islands to represent the urban area. And then the other islands are regarded as rural. And so out of the rural islands, the larger ones have been selected pretty frequently. There's been a mix, really. I can't really say what the statistical approach has been, but it's all randomized.
Okay, very nice.
It's all
Yeah,
randomized.
good.
And so, but we do need to have rural representation in the surveys. I mean, in order for them to be representative.
Okay. Can you list the, thank you, can you list the major surveys? Because it's something I teach the students. I start with the 1988-89 National Health and Nutrition Survey, the one you were involved in, I know, the 2001. It was two names we had for it, Bahamas Living Conditions Survey or the Poverty Study. And then the STEP surveys came after that. So I want them to have an organized, you know, knowledge of the surveys, you know, that the national survey. So when they speak, they can.
Okay, can you still see my screen?
Hi.
Can you still see my screen?
No, that went off.
Okay, so I'll just share again because it's in the presentation.
Oh, you did discuss it. Sorry, I had a distraction.
That's okay. So this is what you were asking about.
Yes. Okay. Yeah. So,
I have to revisit the list to make sure we didn't leave anything out. And I saw that I did leave something out, which is a 2005 STEP survey.
yes.
And if I find
And
the
you,
summary,
right, and then the first one, it was published in paper. I always remember that one, the 1988-89 survey, because it's so dramatic. It showed, you know.
Oh yes.
The national, what is it now? National Health and Nutrition Survey. I think that's the name of that. Oh, there it is. Okay, yeah.
Right.
1989, right. I always start them with that.
Okay.
But the students, you know, need to be familiar with these surveys so that when you speak, you know, you set your situation up from these surveys. You say this was in this year and that was in the next survey, and you show a trend, and you know.
Yes.
That's how you start a public health, presentation.
Okay. I think a summary of the surveys was done, at least the nutrition related surveys.
Right.
So I will try to find that and send it to you.
Okay. So students, you could use that when you present, some of that background information would be good to include.
It's good to see the trend.
Yes, it does show that unfortunately the chronic diseases, it's the numbers have gotten worse. The status, the health status,
Yes.
unfortunately is worse. And obesity rates have gone up, and I think diabetes. The other thing is, how do you compare the studies, the standardized protocols for the STEP surveys, but
the others.
Yes, the others are somewhat different. Yeah.
Because in presenting them, we have to, you just have to say what the methodology was.
Yes.
Because age groups may be different, islands may be different. Just, the methodology is the thing. And it differs from survey to survey.
That is so, yes.
And so we just have to state what was done and what was used, so that whoever is reading the paper could be fully informed. And would know how to evaluate the information. But it's best to disclose everything for clarity.
Yes.
And better understanding.
Right.
And you'd see in some of those journals how they've done something similar. Everything that was done on the subject, they would just list them all and then have the descriptions about each, so that you could then, do your own evaluation based on the information available.
Because one thing I'll always remember about that poverty study living condition survey is that you had malnutrition. And we always talk about overnutrition.
Yes.
But that's 19 years ago, that's 21 years ago. So conditions have changed. I guess we have an over.
Yes, and then you would have seen in one of the surveys.
We still have people struggling with food security, but I don't know if it translates into actual malnutrition. But I remember that, it was a shocking finding. And that stuck with me, from 2001.
Okay.
That we had malnutrition. Small percentage.
Yes. And then some of the students, ages 13 to 15, were also underweight. I think it was about 5%.
Yes.
To what extent, we don't know, but they're just classified as underweight. Because of the social concerns, we may see, further impacts of that in the community. Okay, well, I think I need to dash over to my other meeting now. But if there are any other questions, would you like for me to come back this afternoon? Dr. Moxie?
Yeah, sorry, I someone was calling me on an emergency call.
Okay, no, that's okay. No, I was just asking if you need me to come back this afternoon, because I think I need to slip over to my other meeting now.
Yes, okay. Thanks so much for giving up so much time with us. You feel, you basically got to the end of the presentation. So I think if there are any further questions, they will contact you.
Okay, I
Will
left my
contact you.
email address.
Yes.
So yes, please do feel
You
free,
did an
everyone,
excellent job as
to get
always.
in touch. Thank you so much, and thank you for
But for
inviting me. And,
definitely, you're a standard speaker.
okay, and my apologies once again for the late start. I just didn't
Okay.
anticipate those issues, but thank you
Right.
again, and all
But
the best
thank
to
you.
you.
Okay. Yes, we'll be in touch.
Okay, take care, everyone.
Take
Bye-bye.
care. You too. Right. Bye bye.